Heads up, healthcare professionals, it's time to book your place. MIMS Learning Live South is returning to London on Friday 13th of June 2025, and this year we're heading to a brand new venue, the ILEC Conference Centre. Brought to you by MIMS Learning, this is the event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK, and gain fresh insights that can make a real difference in your patients' lives. It's not too late to book for Friday. Head to mimslearninglive.com/London and get your ticket today.
Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. My name is Dawn Liz Powell, Medical Editor at MIMS Learning. Here with me is my colleague Sangeeta Krishnan.
Hi.
Okay Sangeeta, pop quiz. What does memento mori mean?
So from a series of unfortunate events, I know that it is Latin for remember you will die.
Yes, that's right. We are all going to die. And that rather cheery thought is the subject of this podcast. Well, not death, dying to be exact. We are living longer and longer thanks to modern medicine preventing and treating diseases that once would have killed us. But fundamentally, death is still very much a thing. And people still have conditions that will lead to their death. So today, we will be talking about the role of GPs and other healthcare professionals in supporting people who are at the end stages of their life.
If we're talking about the role of medical professionals at the end of life care, we should probably address the elephant in the room, that is assisted dying. At the time of recording this podcast, the terminally ill adults or the end of life bill is due to be debated again in Parliament in June. Now, if this becomes law, a doctor would legally be able to help a person to end their life. There are a number of stipulations about how such a law should work, but the key ones include a person being 18 years or older, being expected to die within 6 months, and having the mental capacity to make such decisions.
We should be clear that is a big if. We don't know at this stage if assisted dying will become legal. And even if it does, that does not mean it will become NHS policy. As the bill currently stands, medical professionals can opt out of being involved in the process of assisted dying. A couple of years ago, our sister website, GP Online, looked at the arguments for and against assisted dying on their podcast, Talking General Practice. I would recommend having a listen to that podcast because it really does explore the topic in depth. But for the purposes of this podcast, assisted dying is beyond our scope. So let's focus on end-of-life care as it currently stands. Sangeeta, you mentioned that the bill only applies to people who are expected to die within 6 months, but I think the GMC uses a longer time frame.
Yes, they do. Though, of course, the GMC and the bill are looking at it from two different angles. The GMC looks at it from when end-of-life care should be considered, whereas the bill is looking at it from when assisted dying could be considered. Two very different things. Anyway, according to the GMC, patients are considered to be approaching the end of life when they are likely to die within the next 12 months. This includes patients whose death is imminent, that is, expected within a few hours or days, and those with advanced, progressive, or incurable conditions, with general frailty and coexisting conditions that mean they're expected to die within 12 months, existing conditions if they are at risk of dying from sudden acute crisis in their condition, or life-threatening acute conditions caused by sudden catastrophic events.
Yeah, and to add to that, in our module End of Life Care, a guide for GPs and nurses, Dr. Anish Kote-Shah writes there are several clinical indicators that someone could be entering into the last stages of life. These include poor or deteriorating performance status or progressive weight loss. He adds there are also specific disease-related indicators suggesting a probable worsening of a person's condition. NICE says, for example, that poor response to treatment and severe breathlessness at rest can indicate end-stage heart failure. However, NICE does acknowledge that predicting the trajectory of an illness can be difficult.
Yeah, I guess the trajectory will look different for each person and for their individual characteristics. But at least with conditions like heart failure, there might be an obvious sign, such as breathlessness at rest, that the person is coming to the end of their life. In the module we have on sign guidelines in dementia, Dr. Tony Hazel notes that there are no such signs with dementia. She comments that SIGN now recommends that GPs should focus on the needs of the individual and consider moving away from a focus on defining end of life by disease stage.
I know that health services are very stretched at the moment. I mean, when aren't they? But that does reiterate the importance of treating the patient, not the condition. Individualised patient care is always the goal, whatever the condition and whatever the stage of illness. Okay, so a GP has identified that a person is entering into the last stages of life. What are the next steps? Dr. Kotecha says that once a person is identified as approaching the end of their life, GPs should consider adding the patient to the palliative care register at their practice and then communicate to the patient and their loved ones that they are likely entering into the end stages of their life.
I think raising the issue that the person's nearing the end of their life and that medical care should perhaps move to the palliative stage must be quite a difficult conversation to have with someone or their loved ones.
Yeah, though again, that does depend on the patient and the condition they have. I suspect that some patients and their family or carers might be well aware that they are entering into the last stages of life. And regardless of what they personally think about assisted dying, they might be relieved to some extent. I mean, if their quality of life is poor or they're experiencing a lot of side effects of medications, they might not want to keep having treatments if they know they're not going to get any benefit from them and it's just causing them a lot of side effects. So what does NICE say about this?
There is the End of Life Care for Adults Service Delivery Guideline by NICE that was published in 2019, and that says that health and social care professionals should support enable adults who are approaching the end of their life to actively participate in decision making by having in place processes to establish the amount and type of information they would prefer, systems to provide information in a way that meets their communication needs and preferences, and arrangements to review and anticipate their information needs and preferences as circumstances change. The guideline also adds that people delivering end-of-life services should think about the practical and emotional support that can be provided to carers of adults approaching the end of their life and review this when needed.
That does make me think about when these conversations should be had. Even if the person isn't at the end stages of life when diagnosed, if their condition is known to be progressive and likely to cause their death in the future, should the diagnosis be when conversations about end-of-life care start to happen? I mean, before the person enters into last stages of life.
Yeah, I think especially if the person is likely to lose capacity as time goes on, you would need to have these conversations beforehand. In our 3-part series on nursing home scenarios, Dr. Pipin Singh references advanced care planning in each module. For example, we have one module that focuses on Mrs. Smith, a woman who has dementia. Dr. Singh says that her capacity to make decisions should be assessed, and he says both she and her daughter or family member should be encouraged to say what outcomes are important to them, such as maybe they want fewer medication or better pain relief and so on.
So far we've made references to people having loved ones at the end of their life or carers, but of course not everyone does have loved ones. Sometimes they've simply outlived their friends and family, or that just isn't how their life has turned out, which does raise the issue: what happens if a person is entering the end stages of life and they don't have carers or loved ones to support them, in particular if they lack capacity to make decisions?
So now that you mentioned that, it is actually the subject of another module in Dr. Singh's case series. In that scenario, there is a Mr. Reed who has an unsafe swallow, lacks capacity, and doesn't have any friends or family who could support him. Dr. Singh states that in this situation, a GP would need to consider involving an independent medical capacity advocate to help with any decision making.
To recap, so far we've talked about what might signal the end of life and the conversations that might need to be had around end-of-life care. But what does end-of-life care actually involve? According to the GMC, the most challenging decisions in this area are generally about withdrawing or not starting a treatment when it has the potential to prolong a patient's life. For example, antibiotics for a life-threatening infection, CPR, renal dialysis, artificial nutrition, and mechanical ventilation.
And I think it's very important to understand that withdrawing life-prolonging care does not mean no care. Going back to the module by Dr. Kotecha, he talks about the need to perform a holistic assessment encompassing the person's physical, psychological, social, and spiritual needs. And expanding on what Dr. Singh discussed in his case series, this assessment might need to address, with the person's permission, of course, their preferred place of care and death. Any thoughts on future treatment or care episodes, specifically around any definite plans to avoid hospital admissions or sealing of care, and whether they have or whether they would like to appoint a lasting power of attorney for their health. Additionally, through a patient's journey, but particularly towards the last days of their life, regular assessment of their symptoms is of paramount importance. Common and expected symptoms towards the end of life are pain, breathlessness, and nausea and vomiting. Dr. Kotecha says that reversible causes of symptoms, such as urinary retention or dehydration, should be screened for and treated appropriately.
You're mentioning dehydration there, but Dr. Kotecha also notes that both overfeeding and overhydrating can be more burdensome and outweigh any benefits for the dying patient. I would have thought getting the balance right between ensuring you're not doing more harm than good and ensuring the patient isn't suffering from something like thirst must be quite hard, and I'd imagine it'd be quite distressing for loved ones. Knowing the person you care about is probably only days away from death can be hard enough without worrying about them suffering from extreme thirst. Though if the patient is unconscious or only semi-conscious, they may not be aware of it. Dr. Kotecha says that mouth care to avoid or treat a dry mouth is often the best solution, but families need to be constantly reminded and reassured about this.
Yeah, and also going back to breathlessness, we do have a module on managing respiratory problems at the end of life. And that module discusses that the intervention depends on the underlying cause of breathlessness, the stage of illness, the invasiveness of the treatment, and the patient's preferences. For example, draining pleural effusions or ascites may only be helpful if a person has a prognosis of weeks, but it's rarely of value in the terminal phase. It also talks about the use of oxygen. For example, it says routinely using oxygen for breathlessness is not recommended because there is no consistent evidence of its efficacy. However, do offer oxygen to people with symptomatic hypoxemia, that is, when the SpO2 is less than 92%.
Okay, so far we've been referring to end-of-life care in adults. I mean, we'd all like to think that we're all going to live a long life with perhaps a short illness at the end, but that's not always the reality. Some children and young people will have a life-limiting condition, and they too will require end-of-life care. Sangeeta, you edited a module last year on the NICE guidelines of end-of-life care for infants, children and young people. What does that say?
That module states that there are around 50,000 children and young people aged 18 years or younger living in the UK with a life-limiting condition that may require palliative care, and until relatively recently, there wasn't even much guidance about how to support these patients. Similar to adults with a life-limiting condition, children with a life-limiting condition should have an advanced care plan in their medical records, and this should cover things such as the list of professionals who are involved in their care and the person responsible for giving consent, a summary of the life-limiting condition, as well as the agreed treatment plans and plans for the management of life-threatening events.
Okay, and again, just as with adults, symptoms of the condition still need to be managed. However, healthcare professionals need to be aware that the child or young person may not be able to communicate their needs effectively, and clinicians and carers need to assess whether they think that patient is in pain. Also, medication doses need to be calculated using the body weight of the child instead of age weight estimates, which may differ markedly from the norm in life-limited children. Thanks so much for talking about this with me, Sangeeta. What have we learnt? The GMC states that patients are approaching the end of life when they are likely to die within the next 12 months. This includes patients whose death is imminent and those with advanced, progressive, incurable conditions. The most challenging decisions around end-of-life care are generally about withdrawing or not starting a treatment when it has the potential to prolong a patient's life. This may involve treatments such as antibiotics for life-threatening infections, CPR, renal dialysis, artificial nutrition, and mechanical ventilation. A holistic assessment encompassing the patient's physical, psychological, social and spiritual needs should be performed. This assessment might need to address the preferred place of care in death, any thoughts on future treatment care episodes, specifically around any definite plans to avoid hospital admission or ceiling of care, and whether the patient has or would like to appoint a lasting power of attorney. Thanks so much for listening today. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. We have been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Join us next week when I will be talking to Dr. Patrick Holmes about type 3C diabetes.